So today, again, community impact, addiction, and collaboration with child services, social agencies, and corrections. That's what's on for today,
Yeah.
Heather. Announcements. There's free CME. I don't know if you were aware of that, Dr. Bell, but there is free CME. Please make sure you fill out your thing when it gets sent to you, or you get nothing. So just keep that in mind.
No, you get knowledge.
Yeah, well, you get knowledge, but you don't get credit for having knowledge.
Yeah, you do.
Next slide.
Let us know if there's more than one person in your room. Chat us in their names so they also can get some credit and videos on. It's way more exciting.
Or they get nothing. Upcoming echoes. Actually, the motivational interviewing one will be next on lapse and relapse will be next week.
No, 2 weeks.
Excuse me, 2 weeks. Tomorrow we have Demir Utstran. I can't say that. He's talking about from Hazelton Betty Ford Foundation will be talking, and we have some really interesting ones coming up as well. So lots of fun stuff coming. Just keep a note, Wednesday, August 24th, no echo. The last time we had no echo, Charlie texted me and said, "Where is everybody?" And I said, "You didn't listen to the announcements."
Yes, and our last one of these echoes on Tuesdays, you can see we're kind of doing the wrap up, any barriers people have written in on their evaluations and all that. We're gonna kind of tackle that.
All right, again, if you need any help, please let us know. You can reach out to Aaron, myself, or Heather. Our phone numbers are there. So if there's calls or questions, please just pick up the phone. And again, remember that's new Center for Opioid Resources and Education called CORE. There's all kinds of information. So there's going to be lots of the things we've done, recordings, protocols, everything will be on there at some point. It's a work in progress, but it is up.
Oops.
Uh-oh.
I just went to it. Here we go.
Okay.
I'm gonna skip that.
Yep. And so on the Addiction Connection podcast last week.
Today it released on
that's right.
The buprenorphine clinical pearls, the part 2.
Yeah. So all the things that we get questions about buprenorphine, we're kind of going over some of those things, both treatment and how we run our program, just the questions that we get about how to do things. So,
and exciting next week's is we're touching on the sugar addiction. We're going to have a whole series on the actual biochemical, all of that on sugar addiction, which by the way is a whole section in the Least of Us book by Sam Quinones, just so you know.
Yeah. So, and remember, there is a little survey that's been sent out. I know I got it. And
I just got this one this morning too.
Yeah, I filled it out, said all kinds of really good things about me and not so much about Heather. But it's when you get that, please fill it out. And I think mostly Stratus wants it. So they want all this information.
And the state and all the things.
Yeah.
Okay, right. So your objectives, I'm going to try to get these so you actually like what we talk about today. Anyway, so we're going to review. And it's really important to get your community involved because it is important. And I put change the way you think is because that was Kurt's motto forever a long time ago. And so we're going to kind of just review some of the data and why MOUD is important. So when you're getting out into your community, you can say, hey, this is why we're doing this. So we all understand this, that at least if you've listened to us, the benefits, improved survival, improved treatment, criminal stuff gets better, employment, decreased infections, and all the things. People taking opioids have a 10 times the risk of mortality, and this is prescription opioids. So this is one of those things. I'm going to touch on the prescribing and the chronic opioids a little bit more in this talk than we have been, because that's a lot of where it starts in the community to have those conversations. Swedish Study, man, I went back to the archives to pull this study out again. So comparing the 16 milligram a day buprenorphine versus 6 day of detox. So when people, this happens a lot in corrections or in transition places in treatment where the patient will be on buprenorphine or they'll be using, and then you taper them off of their drug of choice by using the buprenorphine. And then you're like, okay, abstinence-based, ready, go. So within a few months, this is basically a 3 to 6 month kind of focused study, 25% relapse on the bup, 100% relapse on the placebo, meaning 100% relapse on the detox people, abstinence-based, within 3 months. And the 20% of those who left treatment, whether they were this 100% or the 25%, 20% mortality. That's huge. And what they showed is if you had more than 2 positive urine drug screens, so ones that showed substances, it was definitely correlated with stopping any type of treatment.
I think those statistics really fit well too with the fact that, roughly when we look at programs of buprenorphine, about 60 to 65% of people are retained. And so it kind of fits right in there with the relapse rate of people who actually get bup, 25%.
So continuing to look at those studies now, all of the patients in that study did get psychosocial support, regardless if they were in detox, abstinent, or on the bup. Decreased the number of opioid positive drug tests by 14% if they were on buprenorphine. They were 1.82 times more likely to stay in treatment. And here was their actual cool little graphic, which we've never pulled up for, but I found it.
Nice.
Yeah, and this wasn't that long ago. Okay, so now we'll talk about the community. We had this in the first time we gave a talk on community was in like August of 2018, y'all. This was a long time ago. And we had this really nice quote in there by Helen Keller, so I just thought I would use it again. So local task force, and a lot of communities have task force. So they have, whether the clinic or hospital is involved or not, there's a group of people in a community that all like to get together and talk about what can we do, what's going on in our community. And so kind of different people to consider to have in your task force. And I'll break these down a little bit more in detail coming up, but the clinic and the hospital, obviously we can give, and we have information about the health of the community. We cannot necessarily obviously say, here's the information, but we have that. The people in the community get to bring insight as to what is actually going on in the community. Most of the time, obviously, members of the clinic and hospital are also members of the community, so they might know some of this. But when we're going to break it down and we're going to focus on very specific elements in the community, there are things that when we had a task force, I would have never known these details from child protection, public health, and all that. So hospital representation, it is important. Your hospital, that is where people go when they have a health emergency, an overdose. They have all that. And so the important part of having hospital representation is really getting the treatment into all different facets. The clinic gives the best practice recommendations to the people on the task force, can talk about the neurobiology, gives that data. They can talk about here's what we have seen as we've started to do MAT or MOUD in our community or in our clinic. Really talk about those things and educate the community members. Always, always, always important, of course, though, to remember Hipaa. This is one of the greatest, one-sided things when it comes to getting information is when law enforcement calls you and says, hey, we just went to this drug bust and we have bottles of opioids with, someone in your clinic's name on it, that definitely the patient doesn't live here, has nothing to do with this. Looks like that patient sold them, gave them, were stolen. So you can get a lot of information from law enforcement. You just have to smile and nod, and you can't obviously give that information back. So it's just always really important to remember Hipaa. So what else does law enforcement do, or what else can they do on a task force? They can obviously give the drug trends in the community. It's very interesting. We were in a community, this is years ago, and we were in this room kind of trying to get them to understand the importance of doing buprenorphine in their clinic. This is a smaller rural community. I don't remember which one at the top of my head right now. And every medical provider, nurse, medical assistant, provider was like, no, we don't have heroin in our community, totally anti. We only have meth. We don't have any prescribing issues. We don't have any diversion. Obviously a very strong statement. And I looked at the sheriff and I looked at the law enforcement peeps in the corner and I said, do you guys have heroin here? And they started laughing. They're like, yeah. It's interesting when there's that disconnect. You sit down at a table and law enforcement's like, yeah, we had this meth lab, don't really exist anymore. We had, this is what we're seeing for diversion. This is what we're seeing for meth. This is what we're seeing for heroin. We have learned a lot about drug trends in our state based on hearing this information. Different areas of the state definitely got fentanyl earlier than other areas. And a lot of that information comes from law enforcement. They also kind of lead the drug take back days, prescription drug boxes, the drop boxes that are at like the police stations or the sheriff department. They're going to be key when we're starting to decriminalize. The best example that happened early on with this was if, a law enforcement in our community picked up somebody for possession, or they found somebody like higher than a kite sitting in the park. And rather than bring them to jail for whatever they were doing, they would call us, we'd see them in the clinic, get them on meds, and then they never had to enter the jail or get charges. That is much more advantageous, obviously, to long-term retention into treatment and long-term sobriety. School district really can talk about what's going on in the schools. What is the drug of choice of your youth and even down to the middle school? In our community, it's benzos is the big one, which is scary now because a lot of benzos are, of course, pressed fentanyl, and these are very opioid naive in the most part, youth. A lot of prevention, a lot of we had in our community, there was an opioid awareness week we did, and they, did different activities around that just to really get that education out. Mentorship, these kiddos don't have, great role models or don't live in a healthy environment. Maybe they live in a home where their substance is being used, or they're in a little bit more of a traumatized situation. Having that teacher, that coach, that social worker at the school to really be a positive role model in their lives is huge. Pharmacy, having pharmacy on board and as part of your task force, patients go to the pharmacy, whether they're picking up their Suboxone, they're picking up any medication. If you have a pharmacist that's rude or not kind or stigmatizing, that is not going to make a good situation for that patient. These patients have a lot of self-shame. They have a lot of self-stigma in a way. And if they're opening themselves up to get help and get treatment, and they go to pick up the med that's literally going to help save their lives, and then they're met with judgment, that's not going to go well. So really having them on board, discussing with them refill policies when we're talking about other controlled substances, like let's not do the 3-day for free rule and get a whole extra month's worth by the end of the year. Do they have naloxone access? Do they have needles and syringes, and they'll do some exchanges there? Or maybe they won't exchange, but there are pharmacies that will give 5 needles and 5 syringes for, just give that. They can really help with prior authorization, a lot of assistance. Having having a pharmacist in your local clinic kind of group can help with tapers. If that's not possible, local pharmacists are really good with helping, write up opioid tapers, benzo tapers, discussing different medications.
I think it's important to understand how big a barrier a bad pharmacy can be to this patient group. And I think that's one thing we always have to understand is sometimes patients won't want to go. And we have ones in Little Falls where they clearly get treated like every other patient. So it's really important to ask them because sometimes they'll be hesitant to ask for things there.
Right. And ask the patients, like, what pharmacy do you go to? Are you having a good relationship? There's one pharmacy that I've been prescribing to more, and they just refuse to have any type of stock. Like, they will only get enough for that patient, and that's it. They don't have any extra, or it's a struggle. And so then there can be delay in that patient even getting their prescription. And that's just not acceptable. County Attorney's Office, this was fun, having the prosecutor or having, a representative from their office sit with us. What's going on in your local drug courts? Like, what are you seeing? Drug courts historically, if there was a certain level of charge, you were not even eligible for drug court. And a lot of the, the opioid charges, your possession charges, they were too high of charges to even be eligible for drug court. Patients in drug court weren't allowed to have MOUD, have Suboxone. And so it was a lot of education, like, no, this is actually a good thing. And just really understanding their they're very hands-on in drug courts, especially like early on. And to have that working relationship, get those releases from your patients, take advantage of the fact that they're getting urine drug screens all the time and they can send them to the clinic. It's just, and they're going to be a good conduit with your county commissioners who hold the purse strings, especially when we're talking about corrections. If you're really wanting to be more progressive, you need your county on board. And you really want to make sure they can gain some of that, get the ball rolling on the whole non-punitive support. You really want the community to get on board with treatment is the better option. Plus, there's a lot of weird policies out there that I just possibly could never understand that let them come and teach us that. Social services, obviously, this is huge. We had a social worker kind of given to us from our social services. She was employed by the county, but embedded in our clinic. Huge. If you can get that in your clinic, get a social worker in your clinic, it's like Kurt always said, like, it was the most important person on our team. And if you can't, because it's just not a big enough facility, having that good relationship with the county and social services, do need a release to talk to that person. But they do the chemical use assessment. So really having that relationship, can we get these patients in if they need to go to treatment? And then because they do the assessments, they're often the ones that are really kind of making those treatment recommendations. And you really want to make sure that you have a say in that. You want them to send your patient, if they need to go to treatment, to a place that accepts, Suboxone. What are the county resources? Every county kind of has different resources, different, strengths. What is available out there? And then insurance. They can help with patients to sign up for insurance, the food insecurity, housing instability, food stamps, whatever is out there. They have that information. So having that relationship just helps your patients along.
I think a lot of times too, when we had patients that came in acutely and had no food, had no money, had nothing, physicians and other providers, we have no idea where to find this stuff. And we would frequently be able to get them food cards and all kinds of things, and gas cards and different things from the county so that we could get them at least to a place where they could stay. Right. So especially acutely.
Well, and to tell a patient who is early in recovery, so let's remember we're working with a frontal lobe that's not developed. So like, let's pretend we're working with a 5-year-old, somewhere in the 5 to 12-year-old range based on brain development, even if it's a 30-year-old sitting in front of you and you don't have any insurance. Okay, you need to go to the county, or you need to go online, you need to fill out all this paperwork to get medical assistance, and then you need to go here, and then you need to go find this housing support. Like, I'm pretty sure I have looked at the online application for medical assistance just to see. It's not user friendly. Let's be real. It's a government service. And so to have a person who's got that brain level in this acute, high stress, very unstable living situation, life situation, having that available resource there, or having that person that I can say, okay, you're going to drive to the county and you're going to find this person and they are going to sit down and help you navigate. That's huge. Public health. Now, some counties have public health and social services. Some just have one office. Everybody is different. So public health, a lot of the communication with the commissioners happens here. They're the ones who do the community health needs assessment. So you're going to get a lot of your local data, like the actual numbers from your community and what needs to happen based on all these assessments that happen every other year. They can, identify different resources and funding things. And then they also do a lot of different prevention things that you can get involved in. Mental health providers. This can be whether it's just mental health providers in the community that do therapy, like just counseling, or you happen to have a treatment facility in town. Having relationship here, because as we all know, sometimes that wait list to just get into counseling is ridiculously long, and making sure they understand the importance of, MOUD, because sometimes mental health providers are very abstinence-based, and so you want to have these relationships. And when a patient goes to inpatient and then they need to transition to outpatient, again, having that relationship can help that patient transition. It helps you as your clinic or your facility when you're dealing with the inpatient place. transition that patient to outpatient. Because again, like putting that all on the patient is very challenging. Long-term care, nursing homes, home health, hospice, this seems like a very bizarre one, but it was very educational and insightful. There are a lot of diversion things that happen in these areas. Nursing homes are bad. These patients don't often have, do they have some dementia? Are they on so many medications that they wouldn't even know if they're getting their chronic opioid that they totally qualify for? And so these are hugely vulnerable adults. And so having their ability to be aware of this, to make sure there's not diversion happening within their facility, which is huge. Knowing the trends over time, as the population gets older and we're going to have patients who are on MAT ending up in nursing homes or on chronic opioids, what does that look like? I think in a month, that is going to be the talk on this Tuesday Echo, is the long-term care and transitional care. A big one is hospice. Historically, hospice, when somebody passes away in their home, and of course they have all the end-of-life medications, usually, historically, they were just left. Like that belongs to the family, and it technically, insurance-wise, does. But like now you have like all this very high-risk medications going out there. So our hospice would start to say, we can dispose of that for you, or they'd give them the Deterra bags or whatever. And if the family refused to let them take it and they did the whole, this belongs to us, that was documented and noted that this is what's going on. And so just really focusing on these little things you wouldn't necessarily think about. Child protection. Child protection is a huge, huge, huge thing. And I could go on my soapbox of my opinions on child protection. And then the guardian ad litem. Some counties have guardian ad litems in Minnesota and beyond, and some don't. So the guardian ad litem is the person that comes in and is the advocate for the child. They're not with the parents. They're not with the county. They're not with anybody. They are there to assess where this child is at, what's the environment for this child, and to help make recommendations and advocate for that child who is not of age to be able to officially speak for themselves. And child protection trends are so important. What do the out-of-home placements look like in this community? Is it opioid related? Is it meth related? Is it both? Is it neglect? What is it? And how can we as a community work on this? What does that look like? Like, let's get mom or dad or caregiver into their MAT program. Can we keep that child in the home? And really working together, because every patient in the universe is deathly afraid of child protection coming in and stealing their kids. No matter what, frontal lobe development or not, they do not want their kids taken. So how do we work together to do what's best for these kiddos, yet understanding that this is a chronic disease and we need to keep families for the most part together and build that resilience and all of that together. Not too soapboxy.
No, not too bad.
And so there are many, 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 many other people in communities. Some of the communities we've mentored had, a task force of like 50 people, depending on your community and your resources. Local treatment facilities, again, if you have that, if you have a really strong AA, NA, or any support group meetings, representation of here's what we have in our community. Sex trafficking, we had Safe Harbor on our task force intermittently. Are there chronic pain providers or different type of adjunctive therapies? Maybe you have a very strong acupuncture presence and that works well. Have them there. We can all learn from each other. Some of our communities are, very tribal. They're right on. They have a very culturally diverse patient population. Have their representation on that task force, because that is your patient population. So the more people that can represent, basically anybody that can touch a patient with opioids or chronic prescriptions or, opioid use disorder or substance use disorder, wherever those patients may end up or contact, that is an important person to have at the table having these conversations. Over time, sometimes these task forces can kind of change flavor. And one thing we found very helpful is, every month when we'd have a task force meeting, or every other month, one of these representatives would kind of give a little, they'd be like the educational part of the meeting. So, the sex trafficking person kind of gave, here's the trends, what's going on. And they would like educate the rest of the task force rather than just sitting around chit-chatting. And it's really hard to not feel like I am the clinic and I am the most important thing because I'm the prescriber. And that's not the point. The point is everyone's important because everyone has to do with our patient population. And so we all can learn from each other. We can all learn these trends. We can all share this information. Anything to add on all that?
Nothing.
Okay.
No, move on.
Okay. So the bigger gaps, the bigger areas in a community that we really need to look at. So emergency departments, pharmacy, social services, again, child protection, and the jails, law enforcement. These are the areas that the patients with substance use disorders inevitably touch one or multiple of these things multiple times. And if we can't catch patients at these points, we are doing a huge disservice. Emergency department, I know we did an entire talk on this, so I'm not going to belabor this, but the emergency department, if there's one thing we always say we would have done better, it would have been going there first. This is where patients go. They end up there after they got Narcan. They end up there after an overdose. They end up there because they want more pain meds or whatever it is, they are there. And I cannot tell you how many times I have seen an ER doctor see a patient and send them home with the instructions, don't use heroin. Sweet, never thought about that before. Gosh, light bulb moment, I'm never using heroin again. I mean, that's just not realistic. So this is the big issue, is just lack of recognition, no protocols, no follow-up, unwavered providers, which of course there is rules with that. And then the patients being overlooked, such as the provider that just says, don't use heroin because they don't want to deal with it or they have their own judgment. And so, are they there because they want more pain meds? Are they wanting help? Are they having an overdose? It's really, this is that point where a physician is positioned to really intervene, and this is a critical moment. We've all seen this. If the more times you've been in an ER in a year, the higher chance of overdose death. So if you've been in an ER 4 times in 1 year, you have almost a 50% chance of dying within that next year. That's a lot of missed opportunities. Big study. This is a huge study. They did this out of an ER, and what happened, they divided these patients into different treatment groups just to see, and you can see that who was doing the best. 78% at a month were still in treatment if they were put on buprenorphine out of the emergency department. Pharmacy, just going to touch on this again. I know we just talked about this, but, really making sure, pharmacies are there. There's a ton of barriers there. I'm not going to belabor that. Child protection, like I just mentioned, patients are so afraid of child protection, so they often don't get help. They often don't seek help. You will have patients show up delivering a baby and they never had prenatal care because they were so afraid of child protection taking their baby. That has changed a lot with the mandated reporting and all of that. We're going to get that on our regular ECHO and an MMA crossover event coming up. Like, what are the real rules in Minnesota? And so it's never about punishing people and stealing their kids. It's about getting the support during that time. Patients often, if they do get help and they have kids, there's not a lot of treatment facilities that can accommodate. If you're a single parent and you need to go to treatment, what about these kids? And so there aren't very many facilities, but I don't think there's any for males with kids. I think it's all moms with kids, and there's not that many. Housing assistance, if you've had too many felonies, you can't even get housing. So now what? So child protection can get involved. This article, which I found fascinating. So if you look at how many mothers who had how many kids, so obviously several of these mothers had more than one child under the age of 16. 99 had out-of-home care. So 99 of these mothers had their babies put in out-of-home care. 42 of them, I lied, 99 of these had 302 kids, my bad. 42 removed at birth. Like they went out of the hospital with, foster. 49 of them were removed from mom when the mom went to the treatment. The 32 that were removed at birth, when they had another child, none of them got to keep custody of their baby. So in case you don't know, if somebody has a termination of parental rights because of child protection issues, substance use issues, and they get a termination, basically, if they have any other kids, they automatically lose their rights. It is almost impossible for them to ever possess their future subsequent kids. And it's very sad. People do very well though, and women do go to treatment, especially if there are kids involved. So this can be a great place and a great motivator for women to get help. And so rather than making it a punitive thing, it's kind of like a little bit of a threat in a way. But when they see their kids and they want their kids, they will go to treatment. I have a patient actually in outpatient treatment right now. She chose that versus losing her kids. And she said, I'm just going to play the game and whatever. She was really going to blow it off, leave, and then go use meth intermittently again. And in treatment, she just had this like epiphany moment where she's now like, yep, this is the right thing. And so it really can help. Criminal justice, this is my other soapbox. We're going to sit on this one a little bit longer. So there's a lot of barriers, stigma, of course, a lot of mental health judgment, a lot of substance use disorder substance, and this can come and attack the patient from literally every angle when you're coming to jail. Medical, correctional, jail admin, the county boards, the commissioners, we don't want to pay for Suboxone in your jail. Like they somehow get to have a say in medical decision-making. Society in general, you are in jail, you're a criminal, peace out. Barriers, medical decision-making. So again, who gets to decide who gets what medical care? Apparently, people who have no medical degree get to decide that. And even providers sometimes, and admin, they won't allow these meds because nope, they need to be clean. They need to be sober. The only way to have anything is abstinence-based, or it's not necessary, or it's that med. There's just so many barriers when we're talking about this.
Well, I think the thing to understand too is that a lot of things with special programs like buprenorphine in jails, in county jails, because it costs money, those are decisions made at the county board level and not by the medical group that's actually giving the care. So understand that sometimes what programs are available are determined elsewhere.
And then the medication selection, there's medications, these aren't even MAT meds, but there are lots of meds on this list, some examples, and there's a couple people on here who have worked in jails and they're laughing because you can't use these meds. They're abusable, they're divertible, you can get high on these meds. We did on our podcast many series of these safe drugs, and you can hear the details about those there. But then even just aside from these meds like MAT, there is a risk of diversion. That is a whole big focus, is what do you do? We don't want to do this med because other people might take this med, and it's just, it just gets the stigma all wrapped around meds. What do you do about a patient who maybe was on buprenorphine, but then they come in and they have meth in their urine, which is clearly not what buprenorphine is there for, but their urine is now called dirty, which is not appropriate. And so now their buprenorphine is stopped. Or a whole gamut of things. Or, they come to the jail and they're on buprenorphine, but we don't want to pay for it. It's, this isn't necessary. And now the patient has to go through withdrawal. So they get punished, even though they are really trying to continue in a positive way in their recovery journey, especially if a person is going in for charges that was a crime two years ago or a year ago, and now they've made all these life changes, and now they're getting punished again by their med taken away for something they did a year ago. So this is what I just mentioned, and it's not even just Suboxone can discontinue. If you're on a high risk med and you happen to have a quote unquote dirty urine, those meds get stopped too. And so patients are just constantly getting punished, especially with mental health medications and substance use disorder treatment medications. And then when we're talking mental health, the mental health services in corrections is just even vastly lacking, even more than it is in the community. There is a high level of mental health in jails. Once all the mental health hospitals closed down, jail seems to be the best mental health hospital in the world. And there's only so much you can do. You know, there aren't psychiatrists in jail, they cost too much. And so you have, you know, the medical providers, physician assistant, nurse practitioners. Sometimes you have a medical doctor who is able to prescribe, but you're asking providers who are not psychiatrists to prescribe meds that they just might not be comfortable with. Like, I remember going to the jails going, what, you want me to handle all of these schizophrenia meds? Like, okay, let's go. And so it's hard. Mental health is just not prioritized.
Well, I think one of the interesting things is that often you don't even I think the way things are handled in jails, you do not need to get an evaluation for 2 weeks. So you have 2 weeks before you actually get a mental health eval. I mean, remember the rules where they would hand them
they're suicidal.
Yeah, unless they were suicidal. So and they would be given a sheet to kind of tell what their problems were, but they did not have to be seen for 2 weeks. And so imagine how difficult that would be for patients in crisis.
Well, and it's, you know, it made sense. It's trying to get the patient, you know, like really understand what's going on with this patient. But I read one of these forms that a patient had been filling out every day in their little journal thing for 2 weeks. And how many times in 2 weeks did I see this patient write, I just want to die. I could hang myself here. Like literally everything in this form for 2 weeks, and no one saw it for 2 weeks. I mean, that's huge. Yeah. Also time. Yes. If somebody's on Suboxone and they come into a jail, you now need to verify it. You have to try to find a different provider who wrote it. Patients come in. Yeah. So Amanda works in a jail, if anyone wants to know that. So there you go. Like these are huge barriers. And
especially with methadone on a weekend, to prove that somebody's on methadone, it's not on the PMP. And so you can't even verify that they were taking methadone. So yeah,
good luck getting one of them to call you back.
Yeah.
So we could let Amanda and Brittany just do the whole jail talk right now for us. And then different jails have different agency involvement. So you not only you have your county that gets to make all these decisions, but you have ICE patients. So immigration patients are in some of the jails have immigration patients. Some of the jail have U.S. Marshals. So these are patients who committed a federal crime and they're going to be facing trial in the state of Washington, but they're being held currently in Minnesota jail because you can't be in a jail block with somebody that you have gang affiliation with, you were the victim of or perpetrated, and there's all these rules in a jail. And so sometimes these federal criminals are literally states away. So who pays for that? The U.S. Marshals. Department of Corrections patients, so patients who are supposed to be going to prison, and so they're supposed to be in prison, but maybe they are only supposed to sit in prison for a year. So they often will just leave them in the county jail. And so then they have a different say on those meds. So there's all these different barriers, especially when we're talking ICE, Marshals, and DOC. If you want even a simple blood test done or a simple medication started, you need to order it. It needs to go through levels of permissions from these different agencies in the government to say, yep, you can give that person their antibiotic for their bladder infection. I mean, it is that ridiculous. So that just causes delays in a lot of things. So a lot of people don't understand this. I didn't. And every jail has a different combination of many of these. Some have women, some do not. So just different things. And then a big thing, and this is being worked on like nationally, if even statewide, but beyond is insurance. Patients, when you go to jail, you lose your medical assistance. Not always do you lose your private insurance, but a lot of patients ending up in jail don't have private insurance. So you lose your medical assistance. So now the county, like Kurt mentioned, has to pay for any med you get. So taxpayer dollars in the county pays for the medications that all the people sitting in your county jail get, FYI. So why do they need that stopped? That's also a barrier when a patient leaves jail because now they don't have their active insurance. There is a delay there, and now we need to get the person into follow-up care. So these poor nurses are doing a lot of extra work. So I am going to throw some data at you. We did this whole jail talk, a whole presentation on this, and this was what I pulled, and it's fascinating. So this is from the Federal Bureau of Prisons. So this isn't county, this is prison. But if you look at this list, drug offenses, so the stars, those are drug offenses. So in the country, 45% of all inmates are in on drug charges. You know, sex offenses, 11%, weapons, 21%. I don't even know where like murders on here, not even on here because it's just actually lower. Oh, homicide, 3%. So you can see like that disproportionate of drug offenses when there's way better options for treatment. If we're looking at Minnesota, this is old data, 27% of all people in our state prisons, this is prisons again, are in drug offenses with sentences that are ridiculously long. You can get a longer prison sentence for having possession of meth than you can for rape in the state of Minnesota and federally. If you look at the disproportionate of populations, up to 22% of our prison inmates are of Native American descent, whereas only 1.3% of our state population is Native American. So you can see that. Shakopee is only females, and almost half of them have active drug charges. And if you look through this chart, it's actually the highest one. Willow River and Togo, two other prisons in Minnesota, over half of them have an active drug charge. This is just more statistics. Who is locked up? Where are they locked up? Incarceration rates, you can see this is prison just climbing. By race and ethnicity, you can see the differences in different ethnic groups. And this is just another pretty way of showing, you know, it shows the state population and percentage of the jail population. And then if we're looking at co-occurring, we already touched on mental health, but a majority of people have co-occurring, a lot of schizophrenia, bipolar, major depression. Hospitals only have about 35,000 mentally ill patients, and this is 2012 data, whereas 10 times more patients with mental health issues are in jails and prisons. So, and you can see that the symptoms while they're incarcerated. So, and you throw that on top of drug charges. And are all of these mental health things mental health, or are they substance related mental health? Just different data, co-occurring substance use diagnoses within the year, previous mental health diagnoses, same stuff, just different presentation. And then the cost. This is what you have to show every county commissioner. You know, the cost of just having drug charges, just having diagnosis of substance use disorder, the cost, you know, related to the crime, $113 billion. This is also very old data. Treating substance use disorder is only $14.6 million, so way cheaper. Incarcerating a person, $24,000 a year. So you can kind of rationalize this out. And then, of course, the first couple of weeks after release from the criminal justice system, way high chance of overdose death. And so this is why it is a place to capture patients, is in county jails, prisons, all of the above. There's research in here, getting patients treatment does decrease opioid use and rearrest, increase retention, increase following up at counties, but it has to be done from within the facility. Interestingly, this is different than most. Most places say methadone is better retention. Buprenorphine, if you start it in facilities, actually has a little bit better follow-up. But this is, again, heroin, so this is a little bit old. And then the big precedent the entire country is now looking at is states getting sued and losing by not offering substance use disorder, opioid use disorder treatment in the facility. I'm not going to talk about decriminalization because I can go on and on about that. All right. And then naloxone, just another thing, how important it is to have naloxone access. This is a community thing, really getting naloxone access in your community, naloxone access points, pharmacies to have Narcan sites, and then the differences in Good Samaritan laws. So if you are at a site and someone overdoses and you call as, you know, potentially someone else who's using, can you get charged with possession? Can you get charged with that? And the differences in how each state looks at it. in summary, it takes a village. It takes the entire community to work together to take care of our actual community, our community members. So all of these different touch points we talked about are opportunities to help patients. Obviously, most of us in here are in medical, so we see them from that perspective, but it is important to really get that whole community to wrap around to focus on that patient and their care.
Perfect.
There you go. There are some resources here because you're supposed to do that.
All right.
All right. Questions, comments, thoughts? Yes, there's comments in there about surveys. So make sure you do your CME things. You'll also get them emailed to you. But
I think it's kind of interesting. I had a patient just the other day who with a child protection issue. And sometimes we think it's only about the effect it has on the parents keeping their children. But my lady actually came home with her child to find her boyfriend overdosed. She gave him Narcan and called 911, and the police showed up, and they filed a child protection because the overdose happened in her home. And so she actually has an open child protection thing that if they follow through with it, she also is a LPN, and her job is in a nursing home. And if she gets that, she will be unable to continue her job if her child protection case becomes an issue.
Even though she herself was not using.
Correct. And in fact, the other problem was that she also has a special needs child, and she is their personal care attendant when she's not working, and she would no longer qualify to take care of her own child. And so we're stuck in this problem with social services trying to sort this whole thing out, but she will literally have no income if this follows through. And so it really is an interesting thing. But the Steve's Law, which actually you can't, if I call 911 and because my friend overdosed, I can't get charged with any crime if I stay at the scene and stay with that patient. And somehow it was different because it was her home. And so the child protection people got involved. So,
and that's where that one little graphic at the end that shows the different areas of the country and how that law applies differently in different states.
Yeah, so it is interesting sometimes how it also can affect their way of. It's going to affect everything. How much money she has, her housing, the whole works, just by one report. So be careful. Not that I'm not saying don't report, but I think there are times when common sense needs to be kind of looked at. So,
and I think, some of these touch points, our first time doing this in our emergency department, it was like a lot of hesitation, all those same barriers we talked about. And we had all the support down in the ER helping this ER doc do this induction. And he actually called her a princess when she walked out, and she came in looking rough. I mean, she was in withdrawal. She looked god awful. And then this was good old heroin days. So she walked out and he's like, what a prince. Like, she was a princess. She's doing great still. In one of our jails that we didn't have an MAT program really going on, but Brittany let us do it because, Kurt and I were like, God, these patients, we just have to. I can't make this patient suffer. And then when you have correctional officers are like, oh my gosh, these patients, like, they look better and they're kind and they're not sick. And it sometimes just takes seeing that first patient do well and seeing the process to really change minds and to convince things. And that's hard because you have to get people to trust you for a minute, and then you see it. And then when you get the buy-in, it's huge to have all those different points.
All right. Well, there being no further questions or comments, we'll let everybody get back to work. All right, everybody, we will see you in a couple of weeks. Otherwise, tomorrow. At Wednesday. Demir is tomorrow.
Demir.
So. Yeah. All right. He's from Hazleton. Should be a good.
He's from Hazleton, but he's originally actually from the Ukraine. So I'm excited because he's going to talk a little bit about some of the different ins and outs. And I don't even know exactly what his title is at this point.
All right. Well, thanks, everyone. Have a good day.